Welcome to this session on circulatory shock. We'll take you through the physiology of circulatory shock and help you understand how to have a clinical approach to managing any case of circulatory shock. Shock is a state of hypoperfusion with lack of oxygen delivery and accumulation of metabolites like lactate. It causes increased morbidity and there's a high risk of mortality. What's important is prompt identification is essential so that aggressive management can be started early. Appropriate treatment is based on good understanding of the underlying pathophysiological mechanism. The categories of shock include distributive, as in sepsis, cardiogenic, hypovolemic, and obstructive shock, which is least common, as in pulmonary embolism. Let's look at the underlying physiological principles that you can apply on a regular day-to-day basis. First, ensure the oxygen content and its delivery is optimized. So how is oxygen transported? We all know it gets bound to hemoglobin and is transported. So the oxygen content formula is nothing but it's a product of hemoglobin concentration and the arterial oxygen saturation plus the dissolved fraction in plasma, which for practical purposes we'll not consider that at the moment. And oxygen delivery is a product of cardiac output and the oxygen content that we just mentioned. It just means the oxygen is delivered when the cardiac output causes a flow and takes the hemoglobin saturated with oxygen forward so that it can reach the tissues. But is that sufficient? Just having a cardiac output, would that be sufficient to perfuse all the vital organs? So, second important point is ensure blood pressure is maintained. Blood pressure is a product of cardiac output and peripheral resistance. So you need the squeeze on the blood vessels so that takes that flow forward. So you got a good blood pressure there. Now, stroke volume is dependent upon three factors: preload, contractility, and afterload. Obviously, you got to think about the heart rate. So there's a rate or rhythm correction required to get the best benefits. You should go ahead and do it. Maintain organ blood flow is the third most important point. See, for the flow to occur, there has to be a pressure gradient from high to low side, as occurs in your garden hose or in a waterfall, as you can see. So what is the formula for flow? To understand that, we got to understand perfusion pressure first. For perfusion to happen, there has to be a pressure drop or a pressure gradient between the arterial and the venous side, or the compartment pressure, whichever is higher. So as you can see, for the brain, it would be cerebral perfusion pressure is equal to mean arterial pressure minus central venous pressure or intracranial pressure, whichever is higher. So if the ICP is higher, the CV should not be considered. So mean arterial, just understanding a bit more about the mean arterial pressure, it is diastolic plus 1/3 of pulse pressure. That's how it's calculated. It is considered the driving pressure supplying organ tissues, or the average pressure in a patient's arteries during cardiac cycle. Very important to understand, there's something called autoregulation ranges. Most of these organs are capable of maintaining, these vital organs are capable of maintaining its blood flow irrespective of the blood pressure within a particular range. Like for the kidney, it can be mean arterial pressure 70 to 170 millimeter mercury. For the brain, it's mean arterial pressure 65 to 130 millimeter mercury. Heart, it is a mean arterial pressure of 50 to 150 millimeter mercury. As you can see, the kidneys are likely more pressure sensitive. It's a filter. And especially the uteroplacental circulation does not have an autoregulation mechanism, therefore it's pressure dependent. So if the maternal blood pressure falls, the fetal blood flow decreases in proportion. So there's no autoregulation, as I just said. And in hypertensive, they may have a higher autoregulation range. They could be a shift to the right. So they may require a higher mean pressure to perfuse their kidneys or other organs. This is quite important and has to be considered in your everyday practice. So monitoring urine output is not a bad idea in a hemodynamically unstable patient, as you can see, because of all these organs, if kidneys are getting perfused and they're producing urine, most of the other organs are receiving their blood flow and oxygen delivery as well. And a mean of 65 to 70 millimeter mercury would be sufficient to perfuse almost all organs. And that's probably the reason we target a mean like that during most of the resuscitation scenarios and transfer scenarios. Now, trying to understand organ blood flow. Organ blood flow is equal to the perfusion pressure divided by the organ vascular resistance. Quite an important formula, because you can derive and understand quite a bit if you understand how the organ blood flow happens. So suppose the cell blood flow is equal to cell perfusion pressure, which is, as we discussed before, mean arterial minus central venous pressure or intracranial pressure, whichever is higher, divided by the cerebrovascular resistance. You see, so somebody has an end organ problem, a problem which is affecting the brain. You would know how to keep the oxygen delivery. All that you got to do is ensure the hemoglobin is correct, the oxygen saturation is correct, the cardiac output is right, the blood pressure is right, and you got a mean arterial pressure around 65 to 70, and ensure the P2 or the central venous pressure is on the lower side, ensure the intracranial pressure is not very high, and ensure the organ vascular resistance is not high. Suppose interstitial edema, it can happen with all brain injuries, can cause increasing the organ vascular resistance. So you know how to address these issues if you know the fundamental principles underlying their physiology or pathophysiology. Right, okay. Now let's summarize. So in summary, I would say always check the oxygen saturation and hemoglobin, that they are within range and optimized. I'll always ensure the heart rate and rhythm is corrected or is appropriate. If fluid unresponsive hypotension, so you're given a preload to a patient or fluid bolus to a patient, they're fluid unresponsive and their stroke volume is not improving and their cardiac output is not improving and their blood pressure as a consequence is not improving. That is, if they are fluid unresponsive and hypotensive, consider it could mean that they have a large preload deficit, a problem with their contractility, a problem with their afterload, or a problem with their peripheral resistance. So be cautious in pushing IV fluids more than like 3 to 4 liters. Contact ITU as early as possible in that case, as they will check the preload status, provide vasopressors or inotropes as necessary. And always maintain a good blood pressure, a mean arterial pressure, to ensure vital organs are adequately perfused. And also monitor the end organ perfusion and function simply by catheterizing, watching the GCS, ECG, the lactate levels. That could help us. Now, this presentation has been brought to you by Dr. Sam George, consultant anesthesia and intensive care, and Anne Mary Anasku, who's one of our FI1 doctors in intensive care medicine, who's put this all together for us. And we work at the George Eliot. Thank you.